According to the DSM-5, alcohol use disorder is the excessive consumption of alcohol which over time can lead to physical dependency. Withdrawal symptoms will appear if alcohol is abruptly inhibited during this stage. What makes such appetitive behaviours corrupt is that they are performed excessively or done so by compulsion to the point of being detrimental to the individual's health, fulfillment of regular day-to-day activities and responsibilities. The propensity of alcohol use in society has many negative outcomes in the institutional health system, such as hospital care, welfare, ambulance, etc., as well as the judicial system, which encompasses increases in crime, violence, property damage, etc. Overall estimates by the World Health Organization maintain that the financial burden of alcohol on countries ranges in the billions of dollars, even hundreds of billions in some cases. Intangible costs are much harder to value financially, but do reduce the overall quality of life of the individual by diminishing their overall physical, psychological well-being. This can be brought about by excessive alcohol use, which may strain people's interpersonal relationships and lead to the breakdown of familial and social relations. It can also cause physical harm through alcohol-related injuries or inspired violence, or through long-term effects such as liver failure and lowered brain functioning. This diminishment can further cause psychological distress through pain, suffering, and trauma. These findings showcase the need for some sort of initiative to reduce negative impact from alcohol-related harms and costs. However, the first step to initiating a preventive strategy will require a comprehensive understanding of the biopsychosocial forces that influence and predict AUD and alcohol use in the first place. Biological factors are the innate physiological influences that comprise of one's chemical composition, genetic makeup, and current brain development of the individual. Derived component is personality, that is, the temperament of a person, which may predispose individuals to alcohol use disorder to a significant degree. A meta-analysis by Dash et al. 2019 analyzed a multitude of studies measuring the associations between personality factors and addictive disorders, and established a consistent personality profile of people who overuse alcohol and other substances. The big five characteristics identified were high neuroticism, low agreeableness, and low conscientiousness. Further biological causes for the initiation of drinking revolve around the reward model, which maintains that the pleasurable experiences of alcohol and other drug substances stimulate the reward system of the brain, hence enticing individuals' pleasure-seeking avoidance behaviors such as through alcohol use. A study by Crum et al. In 2013 reinforced this notion by demonstrating how individuals who reported drinking alcohol as a viable self-medicating technique for anxiety were more likely to become dependent on alcohol. However, social learning refers to the environment that individuals are exposed to and what behaviors are encouraged by it. Peer cluster theory recognizes that peer groups are immensely influential on the development of adolescents and can encourage certain behaviors that are group appropriate. Otang in 1987 validates this through findings that indicate that places or groupings with social norms view alcohol and substance use as permissible or even favorably significantly foster alcohol consumption. The adolescent period is also a crucial developmental stage when individuals are very preoccupied with their identity and social reputation. Shepard et al. Conducted a study in 2011 reporting that health and behaviors are strongly influenced by individual self-regulation and identity regulation. Adolescents often experiment with different cliques and activities in an effort to develop a sense of self, and if they identify with a self that entails drinking, then pro-alcohol related behaviors are more likely to follow. Davis et al. In 2019 emphasizes this by maintaining through their study that exposure to alcohol advertisements can also supplement social norms to further view drinking favorably, thus indirectly increase alcohol usage and further verifying the influence of perceived social acceptability on drinking habits. Psychological factors instead refer to the internal, emotional, and cognitive state of the individual that can either predispose or shield individuals from alcohol use. Previous literature has demonstrated that positive expectancies and attitudes towards alcohol predictably increase users' initial and continual use of alcohol. Moreover, a 2018 longitudinal cohort sequential study that followed adolescents annually up to 9 years established that this relationship is even stronger when this positive belief is conjoined with peers who regularly drink alcohol. The magnitude and importance of individual mental states is even further emphasized by a recent meta-analysis by Breslin in 2018. Maintaining that negative effects such as depression and anxiety is also predictive of alcohol intake and cravings. This revelation suggests that perhaps targeting individuals' emotions to promote more positive effect, while the negative effect could reduce alcohol intake. How do these factors influence each other? Allen and Gabby in a 2013 study showcased that negative emotionality, which is the experience of heightened negative affect and anxiety, was associated with more frequent binge drinking and intoxication if paired in conjunction with higher levels of amphetamine sensitivity. Considering that personality traits, specifically high neuroticism, low agreeableness, and low conscientiousness, can enhance negative symptoms, then this demonstrates that a combination of biological sensitivity to drug-based reward and specific temperaments and emotions can collaborate bidirectionally, leading to an even greater susceptibility to maladaptive alcohol use and addiction. Furthermore, adolescence involves the significant growth of teenagers' brains, specifically the prefrontal cortex. The underdevelopment of such regulatory areas in the brain and limited decision-making capacity of adolescents leads to a corollary where thoughts, emotions, and impulsive behaviors are less moderated, illuminating why risky, impulsive, and emotionally driven behaviors are more likely to be enacted, as put forth by Silveri in 2012. When this more limited regulatory capacity is coupled with exposure to peer groups who partake in drinking habits regularly, then the result is a continual likelihood to drink and the possible development of addiction later in life. Additionally, Gallego Moya in 2014 found high extroversion and low conscientiousness of the individual to aid to the likelihood of drinking in such contexts. Considering that one's self-esteem is molded by the demands of one's cohort, and these findings even further portray the significant relationship between the biopsychosocial forces' ability to reinforce each other, as well as their overall impact on potentially predisposing individuals to alcohol consumption. Organization informs that the majority of alcohol that is consumed by adolescents is during heavy drinking episodes, due to such behavior mainly being caused by social contexts such as parties, clubs, or during the use of other substances. The preventative strategy should aim at reducing heavy episodic drinking through these pathways. Furthermore, a longitudinal study by Dawson et al. In 2008 has shown that the earlier an individual is when they have their first drink, then the higher the likelihood of them developing AUD symptoms later on in adulthood. This illustrates the significance of early on drinking habits. Therefore, preventive strategies are wise to target this demographic to more effectively reduce the propensity of AUD at its source. Tertiary prevention involves moderating already risky behavior to a healthier and more respectable norm. A longitudinal study in 2018 individually tested the effectiveness of varying protective behavioral strategies, with counting drinks being the only strategy that resulted in lowered alcohol consumption. Out of the other 15 strategies, 11 had no recorded effect, while 4, such as using a designated driver or having a friend watch the other drink out, resulted in an increase in alcohol intake. These diametrically opposed results can stem from the fact that applying restrictions may trigger cravings for additional drinks, as noted by the authors. An additional limitation that wasn't considered may be due to the fact that by establishing a plan that reduces the consequences of heavy drinking, individuals are as a result enticed to drink more than they otherwise would due to responsibility for their actions being perceptually mitigated when care is bestowed to others, such as a friend or another driver. By Stuart Brown in 2006 performed 3 reviews of studies that analyzed the efficacy of interventions on substance abuse prevention by attempting to either directly delay its initial use or through health education to discourage alcohol use in general. Overall, a limited magnitude for the benefits of such health promotional interventions was shown, and that strategies to delay initiation at best only reduce alcohol consumption in the short term. Perhaps prevention can be best achieved instead by developing adolescents' resilience and protective factors instead. Holder et al. 2011 study considered this by implementing a cross-grade intervention aimed at promoting better communication, connectedness, empathy, and self-awareness between students. Findings showcased an increase to students' resiliency and protective factors, as well as a reduction in substance misuse. However, this curriculum was applied over the course of 3 years, suggesting that any effective intervention will have to be applied for at least similar or longer durations, signifying that a more cost-heavy investment may be required. An optimal approach for prevention should therefore involve a biopsychosocial alliance that considers the multitude of interwoven factors that influence alcohol use and dependence, plus achieving optimal effectiveness by incorporating procedures that target each of the individual factors. Because teenagers make up the majority of drinkers, and adolescent drinking is a strong predictor of continual drinking into adulthood, then judiciously, the most effective campaign should be targeting this group primarily to maximize the possible benefits with the least resources. Our prevention strategy should imitate that of Holder et al. In 2011 by implementing a curriculum that builds students' self-esteem, teaches self-awareness, and promotes healthier social relationships. From a social perspective, these protective factors will lead to a lesser likelihood to abuse alcohol. From a biological and psychological orientation, the influential power of maladaptive personality traits like neuroticism and negative emotionality will be potentially reduced through the promotion of the aforementioned protective factors. Hopefully, this biopsychosocial approach will reduce the initial proclivity to engage in alcohol experimentation during the earlier years of adolescence and lead to a reduction in the rates of alcohol use in later adulthood. From a cost-effective standpoint, a successful biopsychosocial preventative initiative should delay adolescents' initial use of alcohol and reduce the societal and individual harms of AUD. By investing money into such an approach, billions of dollars in expenses can be alleviated and a higher quality of life can be achieved for the public.